take a look at this slide. This is another one. Pause it, draw it out, remember this slide. We're going to have 4 layers of foot muscle. First layer, abductor hallucis, flexor digitorum brevis, abductor digiti minimi. Second layer, quadratus plantae, lumbricals, the tendons of flexor digitorum longus, and the tendons of flexor hallucis longus. Third layer, flexor hallucis brevis, adductor hallucis. Now remember, adductor hallucis has 2 heads, an oblique head and a transverse head. Flexor digiti minimi brevis. And then remember that fourth layer is going to be the dorsal interossei and the plantar interossei. This is a whole nother way to look at the foot layers and the muscles in each of those layers. What we're going to see is we have 3 muscles in the first layer. Pretty darn easy. Abductor hallucis, abductor digiti minimi, flexor digitorum brevis. Second layer, understand that quadratus plantae is there, the lumbricals are there, and the tendons of flexor hallucis longus and flexor digitorum longus.
So here are the first 2 layers of muscle. First layer is going to be abductor hallucis, abductor digiti minimi, and then in the middle is going to be flexor digitorum brevis. Second layer has quadratus plantae, which is a very interesting muscle on its own right in that it has a distal attachment into the tendon of flexor digitorum. Also, we're going to have the lumbricals and flexor hallucis longus and digitorum longus.
So looking at the third layer of muscle, basically what we're dealing with here is adductor hallucis and flexor digiti minimi. Now remember, adductor hallucis is going to have 2 heads. It's going to have a transverse head and it's going to have an oblique head. Fourth layer of foot muscle, very easy. What we're looking at here is dorsal interossei, plantar interossei. Obviously interossei just means between bone, so that's exactly what these muscles are. Just like we saw in the hand last semester, these muscles are going to be between the bones on the dorsal and the plantar aspect of the foot. So just remember that that's going to be your lowest or deepest layer. So this is another nice little chart. Take a look at how the plantar intrinsic muscles are grouped together, medial, lateral, intermediate. Also take a look at how those muscles are grouped together from a layer standpoint. So here's the other way that we can start grouping the intrinsic muscles of the foot. So take a look at, again, medial, lateral, and intermediate. Innervation works just like we saw in a lot of the other compartments. Compartment of the thigh, compartment of the lower leg. So the medial group is going to be all medial plantar nerve except for the adductor hallucis. Remember, that's the weird guy. That's the one with 2 different heads. Of course, it has 2 different heads. It's got to be weird. Why not have its own innervation, right? Lateral group, lateral plantar nerve. No exceptions. Intermediate group, majority bilateral plantar nerve, except for flexor digitorum brevis in the first lumbrical. So understand those patterns. Those patterns are really going to help with study. They're really going to help with memorizing this material. I know what you're asking. Why do we have all these layers of foot muscles? Other than to just confuse students taking anatomy, they actually do serve a really big function. So what they do is they allow us to dynamically control our arch. So if we really think about it, go back a couple slides when I started talking about the splaying of the foot. And what you can see here, take a look at the picture. In a relaxed foot, what I see is a very flat arch. I don't see much of an arch at all. I start contracting those muscles, and I actually can build an arch. I can actually bring those muscles together, contract those muscles, and when I do, an arch form. So really important to know when you're starting to work with those foot and the ankle patients. You're going to see a lot of them if you work outpatient orthopedics. And I can tell you that's one of those things that I really do with my patients. I really emphasize that point is to work those intrinsics, because they can start working and getting some neuromuscular control over their intrinsic foot muscles. They really can have a lot of success in controlling their arch during the gait cycle and other functional activities. The good news is that the fourth layer of muscle is probably the easiest layer. Plantar interossei, dorsal interossei. Super duper easy. Okay, so like I said, just really understand that we're going to have some layers of muscle here. Now, the other thing to note, and you can see this in the left hand slide, we're going to have a couple tendons. Fibularis longus, posterior tibialis is going to sit deep to everything else too. Remember where those attach. If you don't know where they attach, look it up in the textbook or look it up in the muscle chart. Okay? So understand what we're going to see with each of those layers of muscle. So here's another chart. Again, looking at compartments and looking at the commonality between the compartments of the foot and the ankle. Again, depending on where I'm at in the compartment, I pretty much know what's going to innervate those muscles. Now, as we can see, there's some nerve root differences, especially when we start getting into the deep posterior compartment, and that makes sense. But really just kind of memorize and understand where each of those muscles are. Like I said, I think that drawing them out really does help. So understand where those muscles are located, and then start layering down those connections. Start layering down those commonalities, because if you can start to see a pattern emerge, then it makes it a lot easier to remember this material and then therefore apply it to a clinical setting. So looking at intrinsics now, understand again, we have a lot of commonality. We have a lot of patterns that emerge. Understand what those patterns are. This is something that, again, pause the slideshow presentation, take a look at them, draw them out, write them out, whatever you need to do, but then understand how that foot and ankle is put together, how those intrinsics are put together, and really start to see if you can see some patterns emerge. So taking a look at the tibial nerve is going to travel in the deep compartment of the leg with the posterior tibial artery. It's also going to travel through the tarsal tunnel. So understand which muscles the tibial nerve innervates. Understand which muscles are in that compartment. And then start thinking about, okay, if that nerve didn't work, these muscles would not work. Therefore, I would see X. And do that for the posterior compartment, both deep and superficial. Do that for the anterior compartment. Do that for the lateral compartment. When we look at cutaneous innervation, anterior surface of the lower leg and the medial surface is going to be innervated by the saphenous nerve. Saphenous nerve is going to be a branch off the femoral nerve. And what we see here is the large green area is going to be the area of innervation. So really where this plays into are things like dermatome testing. So we just need to be aware of where those nerves come from. If we know where they come from, we can kind of guess where their root levels are coming out of the spinal cord. And we just need to understand how those how those nerves are distributed, and then how they will clinically relate to an examination. Taking a look at the deep peroneal nerve here. Now, as we can see, much different area of innervation. Now remember that deep peroneal is synonymous with deep fibular, and the deep fibular nerve is going to be a branch off the common fibular nerve. and also understand where the superficial fibular nerve has innervation as well. So sometimes what we're going to see, if you think about it, is patient says, hey, the top of my foot's numb, but my toes aren't. That's weird. And you need to start thinking about how or why that would happen. Or, hey, my toes are numb, but the top of my foot's fine. So start thinking about that and start thinking about how those nerves distribute their cutaneous innervation. So taking a look at the sural nerve. So what they understand is the sural nerve is a branch off the tibial nerve and is joined by the fibular or peroneal communicating nerve. So just understand how that nerve is branched off, understand the distribution of that nerve, and then obviously what we're looking at here is if we have a sural nerve issue, our patients are going to be numb posterior to lateral aspect of the thigh. So really one of the last concepts I want to get into with this section is this concept of the tarsal tunnel. This is a very similar concept. If you remember the hand and the wrist section we did last semester, you probably remember the term carpal tunnel. Well, tarsal tunnel is very, very similar to that. Now, what we're going to see with this tarsal tunnel is that the tarsal tunnel is formed by what we call investments of flexor retinaculum, which is kind of like going to sit over top everything and keep everything in place. And then what we see is we see tendons that are encased in sheaths. Okay, remember those are the Tom, Dick, and Harry tendons. But then we also have artery and nerve that run through that as well. So understand what structures are going to run through there. Understand the tibial nerve and the posterior tibial artery are going to run through that tarsal tunnel, along with tibialis posterior, flexor digitorum longus, flexor hallucis longus.